Dr. Miguel Martin. Dr. Martin is Professor of Medicine and Head of the Medical Oncology Service at Hospital Gregorio Marañón in the Universidad Complutense in Madrid, Spain. Dr. Martin, podium is yours.
Thank you, Dr. Arteaga. Good morning, everybody. I am presenting the results of HICAM-CIBOMA study. HICAM is a Spanish group, CIBOMA is a South American group, Central South American group, comparing capecitabine to observation in triple-negative breast cancer patients with operable disease having received conventional standard adjuvant or neoadjuvant chemotherapy with anthracyclines plus minus taxanes. This is my disclosure. I would like to mention that this study was designed in 2004, so 14 years ago. At that time, no information regarding capecitabine was available for us. As you know, TNBC is sensitive to chemotherapy, to adjuvant chemotherapy, early TNBC, I mean, but a significant proportion of patients will eventually relapse after conventional anthracycline taxane combinations and surgery. So we need new approaches to this population. And with that in mind, we designed a study in which TNBC patients, centrally confirmed in a central lab, with stage 1 to 3 disease, and a prior standard adjuvant chemotherapy with standard regimens, and surgery with free margins were stratified according to the institution, basal phenotype defined centrally by staining of CK56 and or EGFR. We classify patients as basal-like or non-basal-like. Axillary lymph node status and prior chemotherapy, anthrax alone versus anthrax plus taxanes, and then randomized to capecitabine, 1 gram square meter per dose, BID, 14 days every 3 weeks for 8 cycles, or observation. The primary endpoint of the study was disease-free survival, and secondary endpoints were overall survival, subgroup analysis, pre-planned, safety, and biomarkers. So in our files, in our registry, El Alamo, the expected 5-year disease-free survival for a similar population of TNBC patients was 64.7% disease-free survival at 5 years. And we assume that capecitabine will increase 5 years DFS to 73.7%. So the study would need 176 patients for an 80% power to detect a hazard ratio of 0.701. In that table, you have the main patient and tumor characteristics. They were well balanced between arms in terms of median age, region, menopause status at diagnosis, stage at diagnosis, and nodal status. I would like to remark that 55% of patients or patients enrolled in the trial were node negative. In terms of type of chemotherapy received by the patients, you can see here that most patients receive adjuvant chemotherapy alone, because at that time, neoadjuvant chemotherapy was not very frequent. 14 years ago, I remember that. Only 18% of patients had neoadjuvant chemotherapy. 22 patients in capecitabine and 19 in observation entered the study in PCR, in pathological complete response after neoadjuvant chemotherapy, but this is only 5% of the overall population. Around 2/3 of the patients received anthracyclines plus taxanes, and 1/3 AC alone, anthracyclines alone, as adjuvant or neoadjuvant therapy. And here you have the main analysis of the study. After a median follow-up of 7.34 years, we had 105 events in the capecitabine arm versus 120 events in the observation arm, for a hazard ratio of 0.82, and then adjusted hazard ratio according to stratification factors of 8.79, p-values non-significant. So the trial is formally negative because it didn't reach the statistics pre-planned. Nothing in overall survival, similar overall survival in both arms. And when we look at the subset analysis, we found a very interesting information regarding the basal status of the patients. You have here the Kaplan and Meyer curves of capecitabine versus observation. In the left, for basal patients, those staining for EGFR and or CK56. No difference. In the right, you have the non-basal population. A relevant difference has a ratio for disease-free survival of 0.53, p-value 0.020. The interaction test p-value for that comparison is 0.0694. And here you have the overall survival results. In the left, again, no differences in overall survival in the basal population, but in the right curve, the right graph, the non-basal population show a big benefit with capecitabine for a hazard ratio of 0.42 for survival and a p-value of 0.007. In that case, the interaction test p-value is very positive, 0.052. And here you have the type of disease-free survival event we observed in the trial. In the overall population and in the non-basal population, the one achieving the biggest benefit. Capecitabine reduced mainly distant relapses in the non-basal population, and particularly in liver and brain. So to conclude, this study formally failed to show a statistically significant increase in disease-free survival by adding capecitabine to standard neoadjuvant chemotherapy in early operable triple-negative breast cancer, but in a prospectively planned subset analysis, TNBC patients with non-basal phenotype achieved an increase in disease-free survival and overall survival with capecitabine. I have not presented any toxicity data because the tolerance of extended adjuvant capecitabine was exactly as expected. This is a very old drug, so I think this is not necessary. Thank you very much for your attention.
Thank you. Questions for Dr. Martin, please?
Sorry, Pam Harrison, Medscape. You mentioned in 2004 when the study was designed, there was really no data for you to study capecitabine. So I'm just wondering what the rationale might be, because it's my understanding that capecitabine is a radio-sensitizing drug, and at least in other cancers. So was there a reason why you wanted to explore?
Good point. You are right. Capecitabine is a radio-sensitizer in many cancers, but in breast cancer particularly, the drug has been approved after failure of anthracyclines and taxanes. So we hypothesized that patients receiving anthracyclines and taxanes could get a benefit from adding a non-cross-resistant drug. Capecitabine is...
I didn't quite... What kind of drug? I don't know.
Okay, so capecitabine is non-cross-resistant with anthracyclines and taxanes, the usual adjuvant chemotherapy for breast cancer in the triple-negative subset in particular. So we hypothesized that adding a non-cross-resistant drug to the standard drugs could rescue those patients with residual disease and could improve the results.
Could you just comment on your statement about the CREATE-X trial? You noted that results from CREATE-X really it sounded like they were more positive than this trial, and they were at lower risk for relapse, I believe, than the patients in this study. So maybe does this data suggest that patients at higher risk of relapse might benefit from capecitabine, or only the non-ductal carcinoma patients?
You are right. Our study enrolled a population of very, very low risk with respect to the CREATE-X trial. Patients on the CREATE-X trial had residual disease after neoadjuvant anthracyclines and taxanes, so they were at high risk of
Okay.
relapse.
They were
So
high,
the efficacy of capecitabine there was higher than in our study.
Okay, I'm going to read that.
How can we see the create X after our data? Well, I think our data don't speak against the create X study, but maybe the benefit in the create X study is too big to be true. I don't know.
Okay, just the last question. I just wondered, given the disappointing results in the majority of the cohort, is there something that oncologists can tell women with this disease that will give them a modicum of hope that they'll do
Yeah.
all right
Well,
over the long term?
my personal bias is that capecitabine is useful for some TNBC patients. Our study is not finished because we are going to look at the genomic characteristic of the subgroup defined as non-basal-like, because we want to know more about this subgroup. We are planning also to reproduce our results in the CREATE-X trial to see if this is a real finding, because we are in the era of personalized medicine. TNBC is a miscellaneous disease in some way because it's defined by negative findings. So if we could identify a subpopulation of patients that actually benefit from capecitabine, this will be great for the patients.
Next question, please.
Yeah, Marisa Weiss, breastcancer.org. Do we know at a national or international level what, in terms of practice patterns, how often is beyond triple negative, how often is it distinguished basal versus non-basal in clinical practice, like in EPIC or other EMRs? And how much does, as advocates for the breast cancer patients share decision-making, do they even know beyond triple negative if they have basal and non-basal to share decision-making and to not miss this opportunity after initial adjuvant?
Yeah, actually they are not distinguished. Everybody is treated in the same way. But not only every TNBC patient is treated in the same way, all breast cancer patients are treated in the same way with the same drugs. This is a mistake to me. We should select the right drugs for the right patients. Probably not all breast cancer patients are sensitive to the same drugs. But the problem with that is that we have no funding to run trials looking at that, because these kind of trials are not interesting for pharma companies because they are all drugs. So I'm a little despaired that we need trials trying to identify the optimal chemotherapy for different subtypes, but I am not optimistic we can do that. We have tried in Spain to do that, but we have not found funding for that, unfortunately.
Thank you.
But that's an important message, that triple negative is really a big, very heterogeneous group, something that the public may not, we all need some education of that,
Right.
us included.
Right.
That is a very heterogeneous group.
Well, I don't think it's a field in the EMRs, like, when you fill out the staging information. I don't remember it distinguishing basal from non-basal.
No, it doesn't.
It does, that's what
It does not. It's triple negative, which is what
Right.
what is negative. It doesn't have what we know,
Right.
ER and HER2, but it's still a very heterogeneous group.
So
One
for
that is very
patient-
challenging.
Mhm. So is one take-home message to encourage patients who are diagnosed with early-stage triple-negative breast cancer to ask their physicians if it's basal, non-basal, what the subtype is as best we can identify at this time, and to start the conversation that way?
Let's start by educating all of us about the fact that there's a need to do research in that. I think that I'm not sure that that would be a question that I would recommend for a patient to do, but I think we need to just have a national conscience, if you need, that we have a duty to define this phenotype better.
Yeah, thank you.
Yeah.
And
Thank you very much.
Thank you very much, Dr.